Yep.
Great. Okay, hi everyone. My name's Laura Moran. I'm not sure that I've met you all before, but I've certainly worked in the Pacific for quite a few years now around the Civil Registration and Vital Statistics program. I work in the Health and Vital Statistics section at the Australian Bureau of Statistics. So there we look after births, deaths, causes of deaths, and marriages and divorces. But in particular, I really specialise in mortality, including the cause of death program, and feel really, really passionate about producing high quality information that can be used by governments and researchers to inform better health outcomes for people. And I think as we move on to the mortality section, it can definitely be a bit of a morbid topic. So I know that we've come off births last week, where we're really looking at that core program of identity for people, fertility rates, and and it can be a really nice thing counting babies and really focusing on that life part. But the deaths part is really just as important. And I think it's really important to understand that behind every death statistic, there is a person, there are people and families affected, and the better information that we can put together, we can help prevent deaths in the future and help contribute to longer and happier life expectancies for people as well. So I always like to start off with this slide around mortality data. And what the slide is showing here is we've obviously got a map and we've got the different colour coding. So where we see really dark colours, those countries have higher mortality rates. So some of the African countries, we can see that dark red, we're seeing some higher mortality rates there. And then when we come down to the lighter colours, they're lower mortality rates, I should say. And it certainly doesn't mean that there's not interventions and progress that can be made in those countries. It's just overall there's a lower mortality rate. So when we start having a look at the Pacific, we can see that Australia and New Zealand have some of the lower mortality rates. And then as we go up, there's some places up here in the Papua New Guinea region with some higher mortality rates. But also we've still got that shade of orange there that's suggesting that some interventions could be made. So automatically we start thinking about health of a nation. We start wondering around how the data is collected and is this an accurate representation? So we'll have a bit of a think about that as we go through. So I think really importantly, mortality data is an indicator, and we started to hedge at that just before. And it really is giving us an indication of the quality of life. So when we start considering the age of death and some of the causes of death, we can start to gain an understanding of how people are living and also on how their health is going. And health can be affected by very direct factors relating to health, such as diet, and things like that, but it can also be some of those social impacts such as access to services, access to education, and it really is an essential measure of some of these health outcomes. So if we have a look at the graph over here, this is looking at education and life expectancy. And we can see that as some of these education levels increase, so do the life expectancies. But I think really importantly about this graph, what we're also seeing is that the blue is representing healthy life expectancy. So as some of those educations go up, so do the levels of healthy life expectancy. And that's, of course, what we really want for people, is to be living long, healthy lives where they're enjoying what they're doing and they're actually able to participate in the community. And of course, we're interested in comparisons. So if one country has a high life expectancy and a low mortality rate, we're interested to know what types of policies are over there and can some of those things be introduced here. And so comparisons, establishing some norms and some averages are also really important. And of course, with all statistics, this is with both births, deaths and causes of death, that time series is of extreme importance. So how are things changing over time? And I think mortality data has a very long history of being collected, and we really can start to monitor some of those changes as we go through. And of course, the ultimate indicators are those sustainable development goals. And over the last year, there's been extreme focus on them as we've been in this COVID-19 pandemic. But mortality really informs many, many of these goals. So we've got things such as the maternal mortality, maternal health obviously leads to such improved outcomes for infants. We've got preventable deaths of newborns and children under 5. But also infectious diseases such as AIDS and tuberculosis and things like that, where they really are things that can be prevented, and having a look at who's dying of what in each country is really important. And so the mortality data has the capacity to show us this, both at that all cause and cause level. So mortality data is used in many, many different ways. So it's obviously used for population. So it's really important when we're understanding our estimated resident population that if people have died, that we take them off and really monitor proper population growth and put the deaths into the equation. Health planning and resource allocation is also really reliant on mortality statistics. Just recently, my team produced a report on place of death, and what we've seen in the Australian setting is that around half of people die in a hospital, but over time, as our population is aging, we're really starting to see a lot more people die in aged care facilities and special nursing home facilities for people, especially on that palliative pathway. And so for that, it's really helpful for governments to understand what type of facilities might be needed in future, where those facilities should be, and ensuring that we've got enough doctors and nurses and orderlies to help staff those facilities as well. Focusing in on some of the cause of death things, we can start to measure the success of new treatments. So we may have some new treatments in cancer, and cancer rates can be variable over time and very dependent on how somebody is able to access treatment and the type of cancer that it is, of course. Measuring the success of health services, and I think we've all experienced this over the last 18 months as we've really been in this COVID-19 pandemic. So some of the things that have really changed are some of these primary health and public health measures, such as social distancing, also the increased hygiene with things like washing hands and increased sanitation there. But there's also been a really big change in the way that people have been able to access health services. So as countries have been locked down, sometimes it's not so easy to see your doctor. There's been a bigger take up of things like telehealth, and having a look at how many people are dying overall has been extremely important during this pandemic. And I really struggle to think of a greater time when we have focused so much on mortality at that daily level and starting to take those tallies. And that's not just from COVID-19, that's from all causes, because we know that as things such as elective surgeries are shut down, we can have some inconsequential mortality in other causes as well. And of course, providing clues for research. So there's lots and lots of researchers in the health space, in the population space, who are really looking for changes within populations, within different regions, internationally, and having very, very high quality data sets can help some very important studies go forward in that space as well. So really importantly, it's great to know the system where your data is coming from. And so I've just put up here a snapshot of the Australian system. And after that, I would be really keen to gain an understanding of the system in your own countries as well. But when you know the system of your mortality data, it really helps you to explain to users what you're publishing, what some of the cautions may be. So if you're missing deaths or there's an area that aren't covered, you're able to let people know, and people can adjust their findings and their policies accordingly. So you can see that in the Australian system, this is a snapshot for 2019. We had 169,301 deaths that were registered, and registered is a really important thing because we go through the civil registration and vital statistics system here. We have 8 different states and territories, all with a slightly different system. So it's our job at the Bureau of Statistics to get the information from all of those 8 areas and put them together. We've got a fairly advanced coronial system here. So 12% of our deaths come from the coroner space. So some of those violent and unnatural deaths, and where people have died at home and a doctor's a little unsure on what's happened. But most of the deaths go through doctors at hospitals, but nursing home doctors and some GPs also send us information as well. We collect both information on perinatal deaths. So perinatal deaths are very young infants, so less than 1 month, and stillbirths. And then we have the general deaths. So it's really important that if we're reporting on our deaths, that we let people know that for the general deaths, we've taken those stillbirths out, as they shouldn't be forming part of that information. And we should always be seeing that we've got more male deaths than females. So in 2019, the ratio was around 109.1 for every 100 females. And females live a little bit longer than males in Australia. So its median age of death is around 85, around 80 for males. And that information, that general stats and that really quick snapshot is really important for us, just in case something's gone wrong with the way that we've received the data. We can have a look at those and think, well, that pattern doesn't look like what we were expecting. So what happened with that? So I wanted to really spend a little bit of time understanding the systems in your countries. So some of the questions that would be great to go through here is understanding the source of your mortality data. So is that coming through the registry offices? Is that coming through the hospitals and the health system? Is there separate surveillance systems for things? So how does that work? Are community deaths included, or is it just hospital deaths? What do you do that happen with deaths that occur overseas? So in Australia, we only count deaths that occur in Australia, but I know that for the Pacific, many of these deaths that happen overseas can be really important to count. So very interested in that. Also interested in the stillbirths, and just who's using your mortality data as well. So I'm not sure what would be easier for you here. If you'd prefer to put it in the chat, then that's great, but also happy for people to talk as well. So just let me know what your preference is there.
Can I go first? Hi, this is Edlin from RMI.
Hello. Yes, please go first. That's great.
I'm checking if Herman is in the call, but if not, I'll go ahead. Herman is here. Herman, do you want me to discuss, or do you want to discuss it?
Oh, I just came in right now. I missed
Okay.
the quiz.
Okay, it's in the. I can start, and then you can just add if anything I missed. Okay.
All right.
So, okay. Thank you. For source of mortality data, so we do get reports from the hospitals, like the vital statistics is actually located in Major Hospital facility. So we get a report from Ibay Hospital, which is another hospital from a different island. And for the outer islands, we get reports via radio call from all the health centers, and they all report to the outer island health center's office, and our staff come and collect the information. For community deaths, we still get them because most of the time they still go to the hospital or they all go to the health center. So the health assistant also know about any death that happened in the house or at home, and they'll be able to report it. Deaths that occur abroad, we do receive information about that, but we don't add it to our numbers. Also, me and Herman, we're working in the Ministry of Health. We collect the data, we put it into a death certificate, but we forward it to Ministry of Internal Affairs and Culture for them to certify the death certificate. For stillbirths, we collect them and then, I'll ask Herman if he submits it to Internal Affairs, but we collect them and we report them on our data. Any requests for mortality data by government or others in your country? Yes. So we submit key performance indicators to the government every time they review our budget, our information. And it's included the mortality data, top 10 causes of death, number of deaths, number of infant deaths, number of maternal mortality ratio, and then for others in our country, we report also to EPSO, the Planning Office, Economic Planning, Policy, and Statistics Office, who handles our SDG report, IA, Internal Affairs, and other government agency that needs it. Over.
Great, thank you. That was really, really interesting to hear about what happens in RMI. And it sounds like a lot of people are using the data already and you've got good coverage, which is wonderful. And I can see that Michael has put in some things here from Kiribati into the chat. So it's the Civil Registry Office and as well as the Ministry of Health, and also the church has some supporting documentation. Did you have any other things to add, Michael, around the deaths that occur abroad? And also just how some of those community deaths may work as well? Maybe not. At least we've got that much. Would any other country like to go next? So we've heard from RMI. We've got a little bit there from Kiribati, Palau or Samoa. I'm not sure. Sorry if Vanuatu have joined, but would Palau or Samoa like to go next?
Talofa, can you hear me?
Yep, we can hear you.
Talofa, this is Pony from Samoa, the Civil Registrar. Apologies that I just able to connect, and I also send apologies for not attending last week's session because it was a public holiday here in Samoa, and And also the time of our sessions, I think I've shared with Gloria at SPC, because we still have people coming in, so it's a bit distracting while we have our meeting, and it's a sort of disrespectful if we talk on the computer while the people are waiting. So but I'm a bit of a little bit lost on where we are at the moment, but we are more than willing to share our experience if we know exactly where we are, and sincere apologies for that.
Oh, Peony, that's completely fine. So please, if it's rude to talk, please don't feel the need to talk. So it's okay to type into the chat as well, to be to cause as little disruption as possible. I completely understand working in an open office. So sorry, my screen keeps flipping. But basically what we've started with doing is just having a talk about mortality. So last week the births modules were finished. This week we're just starting to talk about some of the mortality data, and just at the moment we're just having a discussion around the systems, so understanding where things come from, whether that is the civil registration system or the health system, and having an understanding of, do you count deaths that occur abroad, who are the types of people within Samoa who use your data, so that type of thing. So RMI have shared that it's the health department, that they don't include the deaths that occur abroad, and there's lots of different people using it. And Michael from Kiribati has put into the chat that it's a CRVS data. So I know that you've worked really closely with Gloria in the past, so which is great. So this is really just an extension on some of those conversations. So please don't feel too stressed, but if you want to add things into the chat, that's great.
I think since I still have the floor, and I think there's we want to utilize this opportunity to share Samoa's experience on mortality registration.
Wonderful, thank you.
As I mentioned earlier, I think during the second session of this training, that according to the PDM Act, the Births, Deaths and Marriages Registration Act 2002, we are mandated to register the deaths within Samoa and also the deaths outside of Samoa, occurred outside of Samoa. But our main source is, when we talk about CRVS in Samoa, the key stakeholders are also included, like the Ministry of Health, the private sector. In that case, there are funeral morgues, funeral parlors, the services where the deaths are located before they take out to burial and all that. So we included them, and also the Ministry of Women and Social Development, who directly deal with village representatives. So the major stakeholders in terms of mortality in Samoa is our Ministry of Health, because we believe that the majority of the population are dying at the hospital, and we get our linkage with the Ministry of Health is I can say that is strengthening at the moment, is much better than before. But the only problem is the linkage is getting better, but just between the PDM and the main hospitals, like the main hospital in Abia. But we don't really get the data from the hospitals at the rural places and also the other islands, outer islands. So but most of the deaths occurred at the main hospital, so that's where we get the data. Even the data from the hospital, because they have their own system registering deaths, so they don't register deaths occurred outside of Samoa. The Ministry of Health don't register deaths occurred outside of Samoa, but the BDM do register under their mandate. So that's the difference between the two, and also some weaknesses that we have identified in our colleague our dear Ministry of Health system is the system is not connected to the outer hospital systems, so they only have the data and the deaths occurred at the Ministry of at the main hospital. So we get the death data on monthly basis from the Ministry of Health, and we input those information while we are awaiting the families of the deceased to come and complete the registration and pay the necessary fees. And also the good thing with the deaths occurred at the hospital, I think it all goes to the rest of the Pacific Islands, is we have the cause of death certified by the doctor. But for deaths occurred in the community, back in the village, they normally take those deceased to funeral parlors, funeral morgues. So the cost of death is not determined. So when they bring the documents to register the deaths, we cannot register any cause of death, although we get the information from the family that this disease was had a heart attack or whatever. So we are not mandated to guess or to register any cause of death that is not certified by a medical profession. I think that's the issue with deaths occurred in the community. And but we do, as I said before, we do register the deaths that occurred outside of Samoa, or the Samoan citizens died in overseas, but we do need the necessary documents, because if they we know that for example New Zealand and Australia, they have really strong CRVS systems, so we get we do need the proper documents from that respective countries where the disease occurred to register the deaths here in Samoa. At the moment, we are engaged with one of the projects that the TH4 mainly focus on reviewing and analysis and redesigning the CRVS processes. So our local consultant is on board today. I think we're doing this in conjunction with under the help of the UNESCAP, and we're looking forward to improve our processes after this project. And on that note, we also apologize for not attending most of the previous sessions, because we are under our plate is really full. We've got a lot of other priorities and projects on board at the same time. And not only that, we got people coming in the office, because we close to the public at 3 o'clock, but we in local time, but our session start at 2 o'clock. So we still we have to, we find it challenging to trying to accommodate to the other priorities and also the people coming in, because that is our ultimate priority, is saving the public that coming in the office every time. I think that's all from Samoa, unless you have any questions that our other colleagues.
That is wonderful. Thank you so much for sharing that, and some really interesting information around how you treat some of those deaths that occur abroad. And was also really happy to hear about some of the relationships that you spoke about with health, with other countries, but also with the funeral directors, which sometimes I think that we can easily forget about in the registration of deaths, but they're also a really important data source. And so I think we've covered off some really good points that will be important when we're producing some of our mortality mortality data analysis as well, to go through and completely understand juggling multiple priorities. Serving the public is, yeah, definitely the most important thing in getting those identity documents out. And we've got a little bit more information. It's interesting that each country differs slightly as well. So Michael's also added that the stillbirths are registered in the death records. So we'll just have to make sure for Kiribati, Michael, that they're taken out. But Alison gave us some information for Palau as well. So it sounds quite similar to Samoa in that some of those deaths abroad are really important to understand for the health planning as well. But also Palau has the Ministry of Health data. So it sounds like we've got both CRVS and health data. So we'll think about that when we're outputting it, because we can get some different figures. Now I'll pop back to my slides, and apologies, I have to keep flipping around. Oh yes, sure.
Can I just say one thing? I think I forgot, but it may significant to our discussion and our course. I think one of the issues that we encountered, we have encountered most of the time in terms of death registration is when it's that links to the social benefits. For example, the insurance. And that's where we have encountered a lot of problems in terms of the informants. For example, what our normal practice is, we consider the immediate relative to come to register the death and issue the death certificate to that. For example, if the father is deceased, so we need the wife, or if not the children over 16 years of age. But where we have encountered a lot of problems is the marriage couple. For example, if the father is deceased and I have a lot of benefits, and I have a second wife, is we didn't have a legal divorce with the first wife, but in terms of death registration here in Samoa, we consider what is illegal. So although that I have a second wife, but our first marriage is still valid, so the first wife's name will be included in the death certificate, but not the second wife. But I think that those are some of the issues that we have encountered during the registration. It may have some sense to our course, because it creates a lot of issues when that specific death certificate linked to social benefits like the National Provident Fund, the insurance, and and all the other financial benefits exist.
So that sounds like a very sensitive situation if we've got different marriages affecting the way things can be registered. So it's sounding like some of these systems are very, very complex, and a really good consideration of how this data comes together and how we need to consider it when we analyse it. So thank you for sharing that. That's really very, very interesting. And I think that leads really nicely into thinking about some of the social parameters that affect mortality. So we've very much just thought about the system and how the system can affect some of those numbers that we're getting through and some of the demographics. But the social aspects of mortality are also very, very important as well. So when we're considering the population, the composition of the population is going to largely affect our mortality. So if we have an aging population with high numbers of people in their 70s and older, we would expect higher deaths because we know that death at some point has to occur. And when we've got those really populations with lots of older people, we see those higher rates. And that's certainly what we see in Australia here. But also how some of the health services such as immunisation, such as maternal health care and other primary aspects with that start of life program how they're used, how they're accessed, how they're successfully rolled out. That will also affect what we see in the population. So if we know that there's some poor uptake in some of these maternal health programs, we may see some higher maternal mortality or higher infant death rates. Environmental conditions certainly cannot be overlooked. So this can be very direct things such as our housing and water supply and our sanitation. But I think more and more we're now seeing that some of these lifestyle factors and the way that we're living can also relate to some of those social things of mortality. And I was just mentioning earlier some of the things that we've seen in COVID-19 in some of those stoppages of elective surgeries, cancer screening programs, and not being able to access those. And there's a really high interest in how that would affect mortality overall. But of course, things such as abuse of alcohol and tobacco and drugs in some countries and how that's socialised will affect mortality. And we know that they normally affect mortality in younger people. So if there's high usage of those, we can see higher numbers of those younger deaths. The type of work that's very common in a country, and whether people live in a war zone or a place that's really very prone to natural disasters can also affect that mortality rate. And we covered off education earlier, but income is also a really important indicator for mortality and socioeconomic status. So we've heard as well that governments and researchers from all the countries here today are already requesting the data, which is really great and really interesting as well, that especially in some of those things around benefits and stopping benefits, so where it's used not just for research and for policy, but also for very direct things such as shutting off payments and things like that. So mortality data is really important, both at the individual level and at that statistical level. But a few really important things is that data needs to be comparable. So we really need to be comparing apples with apples. And this is where it's really quite interesting hearing about some of the differences between the countries. So if once we've got all the rates together to compare some different mortality rates between this group, we would definitely need to consider some of those things that we just talked about, such as the different source. Do we have all of the community deaths in there? And that type of thing is important. But that internal comparability within a country, so we can compare some of those mortality rates over time, are of extreme importance. So often with our mortality data, time is the one thing where we can really measure change, and change can take a really long time to come into place. So sometimes it's great when we've got all of these new interventions and we know that they're I guess affecting mortality in a positive way, that the rates are coming down, but we just need to make sure that we're adjusting some of our data so we can understand that. Because we're always looking to improve lives of people with our mortality data, it should be able to identify some of our vulnerable populations. So some of the things around age, sex, ethnicity can be really very, very important, where people are living, where people are dying. So if there's something very, very key for your country to understand, it would be important that you can capture it. And if you can't capture it, really outline why it's important and why it can't be put in there. And there's all different types of measures that we can use to measure mortality. So there's numbers, there's mortality rates, and also proportional mortality. So we're just going to start on the numbers and the rates today, but we'll keep going next week. So absolute numbers and crude death rates are what we're going to cover off next. So just before we get into that, I know that in the second week that you covered off data cleansing and really thinking about some of the things that are within your data to make sure that it's a really clean, robust data set. But there's just a couple of reminders that I was hoping to give right now. So very similar to the births data, we really don't want duplicates in there. So if there's some merged civil registration and health data, it's important to remove any duplicates. Occasionally, even within the same system, we see some duplicates as well. We really want those fields filled in around the age, the date of death, sex, place of death, and usual residence, because they do really fill in where we were just talking about before with some of those important indicators and to help measure some of those vulnerable populations. Also, consider the scope. So we don't want stillbirths in our general deaths. So if stillbirths are part of your perinatal deaths collection, just make sure that they're separated for reporting purposes and they have their own section, just so we don't mix them up in our population counts and our overall rate. The deaths abroad, it depends on how you would like them in your scope, but definitely explain if they're there, that they are there, and giving some proportion and idea of how they've been counted. So some of the information that we heard from Samoa, for example, that it would have to come with documentation from the other country to be registered appropriately, and Palau had a few different things on how they would consider them as well. So ensuring that that's there so people understand. And also things around the community and the hospital. So if the community deaths aren't in that data set, just ensuring that you explain that so people know when they're reading through the report what they're actually analysing. And something that can be quite helpful for cleansing the mortality data is just having a little bit of a look at the causes of death and doing a bit of a consistency check, basically. So we're not doing any cause of death analysis, but if you see something like old age with an infant, or you saw a female who'd appeared to die from prostate cancer, you might start to consider some of the quality of the death information that you're getting through, not just on the cause of death, but the something could have gone wrong with the way that you'd received the record or the way that you're loading it up. So that can be a really good exercise to undertake, just to understand what's in the data set. So let's start off with some simple tabulations, and this is where we're having a bit of a think about our absolute numbers in particular. So this is just something that I've taken off our mortality publication. So you can see that at the top line there, we've just got the numbers of deaths, the numbers of infant deaths, and then we start listing our age standardized death rate, our crude death rate, and our infant mortality death rate. Now, the absolute numbers are quite important they really are in their own right. There's something that can be picked up very, very easily and understood. So people understand that the number of deaths that we're published relate to the number of people in our community, and so they can be a really good starting point for communication. It does resonate with the community, and I think really helps the community understand that these are people, and that by working on our mortality data, we should be able to improve lives in the future. Especially during things such as the COVID-19 pandemic, having a look at really regular numbers of deaths can be helpful in short time frames. So as we go through over time, numbers of deaths can be less helpful, but in really short time periods when we would expect numbers to be quite similar, so on a day-to-day basis, we wouldn't expect numbers to change drastically. Even across years, we would expect them to be quite comparable. And so they can be very useful from that perspective as well. And of course, for health departments, numbers of deaths are extremely important. So even if we're saying that we have 2,000 deaths one year and 2,100 deaths in the year afterwards, that may lead with population growth to a decreased mortality rate. However, for doctors and nurses and other health professionals, they've still had to treat 100 more people. So raw numbers from that perspective are also really important, just to understand how many people are accessing services and how many people do need some type of intervention. And of course, deaths are the basis for all further calculations on age-specific and age-standardised mortality. So we like to make sure that they're quite accurate from that perspective as well. So let's start with a question before we hop into our rate discussion. So if people just want to put what answer they think it is in the chat, it's which country has higher mortality. So country A had 65,000 deaths in 2020, but country B had 1,000 deaths in 2020. So does anybody want to put something in the chat and we can discuss that?
Maybe if you show your, you can show your slides again, and then I can tell you if there's some messages.
Yeah, thank you. That's really helpful. It's not letting me keep it on both of them, unfortunately. I'm not sure why it's doing that today.
So Alison is saying, don't we need population numbers to find answer?
Yeah, perfect, Alison. That's definitely what we're asking about. So the number of deaths alone, so obviously the 65,000 deaths is a higher number, but really to understand who has the higher mortality rate, we absolutely need the population data. So we can see here that we've got 65,000 deaths for Papua New Guinea, which was country A. We've got a really very big population there, and Tonga is 1,000 deaths with a population of 106,000. So it's quite a different looking countries across the two of them. And as I mentioned before, that sometimes the number of deaths really just does reflect the number of people in the population, but also the age construct of that population as well. And actually, I should have actually produced the rates for those so we could have a look, but we'll come back to those at the end. So then let's have a talk then about the crude death rate, because then we can use those to work out our crude death rate. And it really is the most frequently used measure of general mortality. And so the crude death rate is telling us as a basis per population how many people actually died. So we define our period. It's normally a calendar year. And we define our population, and then we multiply it by 1,000. It doesn't account for those age differences or a composition of a population, though. Sorry, I'm just going to jump ahead to this slide because let's talk about the actual formula, and then we'll go back. So when we're calculating the crude death rate, it's really the easiest one to calculate and very, very, very similar to our birth rate as well. So we take the number of deaths in our period of interest, and so that is normally a year, and then we divide it by the midpoint population for that same period of interest, and then we multiply by 1,000. Now, for this one, if the numerator is going to be too small for 1 year, we often will group 5 years worth of data. So we just have to make sure that if we're going to use 5 years of data, then we divide the numerator by 5, and then we divide it by the midpoint of the population of interest. So once again, crude death rates are really easy to understand, so that's why we use them. It does consider the population, even if it's at a very broad level, and it doesn't require too much information. So we can just take the number of deaths, and we should have our population from some of the other things that we're doing. So we do need to understand where we're taking our population from, if it's a projection from the statistical agency, or if it's a census year. But really, we're taking a very simple calculation and providing something that helps us to understand how mortality and population growth relate to each other. So we've got some examples here for crude rates in small populations. So I think this will help us because I know some of the countries here do have small populations and we will have to group the number of deaths. So our numerator then, we would take the number of deaths across 2013 to 2017. So we're saying that that is 250, sorry. And we still need to divide this by our midpoint population. So our midpoint population for this type of formula would be 2015. So why are we doing that? It's because 2015 is in the middle of this 5-year block. So we've got 2014, 13, 14, 15, 16, 17. And by taking the midpoint as 2015, we can then take 250 to get that. And then, as we were going back through before, we then still need to divide that by 5. So, but we've taken this. I think actually there's an error. We should be dividing this by 5 to get that an annual rate. So this is the rate for that whole 5-year period. But if we want to say that the average annual rate for this period is something, then we need to divide this by 5 as well. So if you don't mind, I'd like to add in a slide for next week because it's actually really important. Normally we would talk through annual average rates, and I feel like I may have just confused you by giving you a rate for the whole 2013 to 17 period. Then we do the exact same thing by sex. So we take the population for males, females, and people. And as we were saying before, crude death rates are normally higher for males than females because the number of deaths are higher for males and females. If we've got deviations from this pattern, we need to understand why. This could really relate to some of our maternal health issues, some of the disadvantages as well that girls could face in accessing health services and education. The crude death rate's also normally reported with confidence intervals, and we'll examine that next week. But really what we're saying is we're trying to get an indicator of how confident we are that the rate is reflective of the population and falls within a particular range. Okay, so we've got a question here. And it's which country has higher mortality? Country X had a crude death rate of 9 in 2020, and country Y had a crude death rate of 6 in 2020. So if we do a similar thing, so remember at this point, we've accounted for the population size. So we're knowing that one has 9 deaths per every 1,000 and another country has 6 deaths per every 1,000. So does anybody want to have think about any considerations of how we can compare these two crude death rates and things that we might need to think about? No, I can't see the chat. I'm sorry.
No comments yet.
Ah, okay. So I might just move on because this one is quite a difficult one. So the crude death rate, what it doesn't take into account is the age structure of the population. And age structures can be very, very different across countries. So populations that have much larger proportions of younger people will have generally a lower rate compared to much higher proportions of elderly people, because we know that we have higher rates of death in very old people. So a crude death rate of 9 may just indicate that we have a country with many, many, many more old people, and the crude death rate of 6 could be considering the younger population. So next week we're going to talk through standardizing that and how to take age structures into account. But that's just something to consider as we're going through some of the homework for this week and starting to consider just what our crude death rate is. And as I mentioned before, crude death rates still are really important. They give that automatic indicator of what your country's death rate is for the population. And within your country, unless there has been huge population change within the last couple of years, you can still compare it within a short time series to get an understanding of whether your death rate is going up or down, and if we're having a look at it by males and females as to how that's changing across sex as well. So you can see here, this is what I was just mentioning before. So country A has very high amounts of older people, especially in the females. It did say that was Japan. And then country B had a higher younger cohort. So because we've got far more people in that younger cohort, the crude death rate looks lower, but that doesn't necessarily mean that the death rate overall is lower. It just means that we can't compare those two countries to each other because they're very, very different looking from a population perspective. So understanding the numbers that we can use to produce a crude death rate. So generally research finds that if we have less than 5 deaths per year or for any period of interest, then we shouldn't be producing a crude death rate. We really want a much higher number to be producing it. It would not be a significant rate if we did that. And the smaller our numbers are, there's a lot of noise in that rate. So even 5 is a very, very small number. So if you had 4 deaths, for example, and produced a crude death rate, you would treat that number with extreme caution, as you would expect there to be a lot of volatility in the number of deaths going over time. Now, for an overall number of deaths, when we're just talking about deaths and not by cause, in all of the countries that we've got online, we're definitely expecting more than 5 deaths per year. So that's something that we shouldn't need to worry about. But if you're going to apply the same formula back to causes of death at a later period, just remember that around if it's less than 5, you need to consider other things. So you could consider grouping years together. If you're looking at males and females had 3 deaths but males had 8, you can consider joining together males and females and just analysing people. So keep considering different options as how you can increase your numerator going there. Now, before I go to the graphs, I just want to go back to this formula just to make sure that everybody's got it there. So we are taking the number of deaths in our period of interest and dividing it by our midpoint population and multiplying it by 1,000. And that's how we would get our crude death rate. So when we do produce our crude death rates, because we normally do a time series, just a few reminders that time series normally work really well in a line graph. And then that can really show the changes that we see over time. So just something to keep in consideration as to how you're going to present the data as well. So for this week, we want some clean death records, and we do want to start tabulating our deaths. So the first one is more simple, that it's just going to be by sex and by year, and it's the total number of aggregate deaths. And then we're going to have a look at some different age groups and sex. So for the age groups, it can be important to remember some of the things that we've talked about, that we would hope that there would still be over 5 deaths in that age group. If not, you might need some broader age brackets, but keep having a look through that. Deaths by ethnicity, deaths by usual residence. We're not going to do the proportions, so just these tabulations, and then we're going to compute the crude death rate for your country. So we need to make sure that you still have the population that you've used for previous talks, and also then we can have a talk about the key points that you're seeing in some of those crude death rates, and have a look at the population as well. Now that's all I had for today. Did anybody have any questions before we finish? Is everybody feeling fairly comfortable with producing a crude death rate? I'm sure that most people, I know we've got some stats agencies on the line, have done that before, but is there anything that you'd like to go back over again, or otherwise we just wait to the tutorial? Alison has a question for off-island deaths and whether you include them. So, Alison, normally when we produce our death rate, so I think it's really important just that you outline the scope of what you're analysing. So if off-island deaths are really important for your national statistics and you would normally include them, then still include them, but outline how many off-island deaths there are, and it might be useful to still do a separate analysis on those as well.
Okay, so what do you mean by outline? Like, does it have a separate worksheet for them and have one for on-island and off-island?
Yeah, I think just so people understand, just in case they're a different type of age demographic, so it could be a very specific type of death that's happening off-island. So I'm not sure if people who die off-island are more likely to be receiving maybe some specialised care for cancer or something like that. But if they are, it could be quite a different demographic. So it could be important to just outline what that group looks like. But if they should be included in your overall death rate, because that's the scope of your statistics for Palau, it's important just to keep that time series really, really steady.
Yes, because most of our off-island deaths are actually residents, citizens and residents who are medically referred off-island. And then, you know, they pass away. Yes, for cancer, for various other diseases, and they pass away and then they're brought back home.
Yeah, okay. I think that makes a lot of sense. And I think that it sounds like a cohort that if you were to exclude them from your death statistics, it wouldn't actually be an accurate representation of the number of deaths that are being experienced in Palau. So I think it's for you because they are normally in your scope to include them. But whether you put it in a paragraph or a footnote or something like that, just to say that this many deaths happened abroad, for your purposes, you include them.
Okay, understood. Thank you very much.
No problems. And is everybody's feeling comfortable with the Crude death rate formula?
Yes, I think we just need to go through the tutorial, if anything.
I have a question.
Mm-hmm.
In line with Allison's question. If we don't count them, like most of our medically referred patients that died, they died in Hawaii or in the Philippines, where most of our cases. Do the country like Philippines or the US count them in their statistics?
Yes, yes. So they definitely would. And actually both countries do, because I've done a little bit of work in both. So they are also similar in that if a person dies in that country, they will include that person in their mortality statistics. So they're definitely getting counted. It's more that if there was some important reason that you needed to be aware of some of that, then you could outline it. But it sounds like for RMI that your scope is fairly clear, that you're only including people who die in RMI. And so it would be important then that you didn't include them for RMI. So just keep within the scope. So it just keeps going on with what you would normally publish, and that your time series is comparable.
Okay, thank you.
No other questions then? Okay. There'll be the tutorial, but also next week, before we talk about the age standardized rates, I might just go through an example of how you would, just a recap as well, because the age standardized rates are a bit more complex. But I think most of that will come up in the assignment part of it anyway. Euless or David, did you have anything extra to add, or Chloe?
No, nothing to add from me.
Nothing to add from me, Lauren. Thank you for a very interesting session.
No worries. Well, it's 12:15, so we've nearly gone for our whole time. So I guess we can leave it here and everybody can gain a tiny bit back in their day. I know you're all very, very busy, so thank you for your time. And yeah, really looking forward to seeing how the reports come together.
Thank you. I'll see you next week.
Thank you very much. Have a good week.
See you later. Bye.
Thank you, Lauren, for a wonderful session.
Thank you. Enjoy your week. Take care.
You too.